This is a 38-year-old female with poorly controlled diabetes who was referred to our service with a traction retinal detachment in the left eye. She had lost vision about 1 year prior and had not sought medical care. On exam, vision was light perception, and she had a traction retinal detachment involving the macula. After discussion of the risks and benefits of surgery, as well as the guarded visual prognosis given the chronicity of her vision loss, she elected to proceed with surgery. The patient was found to have an extensive traction retinal detachment involving the macula. The optic nerve was hidden underneath the membranes and was not visible. Core vitrectomy was performed across the 12 clock hours to separate the peripheral vitreous skirt from the central vitreous. Using a bimanual technique, membranes are gently grasped with the forceps and separated from the underlying retina with curved scissors until the traction membranes were completely released. This was done with extreme caution, taking care not to create any iatrogenic breaks in the process. Large fibrous tissue was gently lifted off of the nerve and then removed using the cutter. This allowed an en bloc removal of the membrane centrifugally from the optic nerve towards the periphery. The remaining membranes are removed using the cutter. The membranes are completely removed. There is a minimal hemorrhage over the optic nerve. Peripheral vitrectomy was completed across 12 clock hours with scleral depression. Air fluid exchange was then performed, and the soft tip cannula was used to drain thick subretinal fluid via a nasal retinotomy. 360 degrees endophotocoagulation was performed, followed by an air 14% C3F8 gas exchange. The case is now completed and the retina remains attached. This is a color fundus photograph of the surgical eye 1 month postoperatively, where the vision in this eye was 2400.